So, Keith, welcome to the program once again. Thank you so much. Where is Keith? I can't see him.
Well, you can't see him because he's on Skype.
Oh.
Share the screen.
Okay, well, we'll say hi to Keith after he finishes his talk then. Keith, well, can you bring him up so we can say hello to him?
Well, he'll have to minimize his...
That's he has to do.
Oh, okay. All right. Well, Keith, go right ahead and we'll bring you up and show everybody what you look like later.
Perfect. Thank you, Joe.
Okay, go ahead.
Okay, so starting tonight, I wanted to thank you, number one, for inviting me to participate in this. And number two, I've got two-part slide presentations. The first one is on a multidisciplinary, multimodality approach to autologous blood conservation. And the second part is going to be more on the fluid volume dynamics. But it all has to do with blood management or fluid management more specifically. So I'm just going to start right now. Okay, my disclosures for tonight. I'm the president and CEO of the company and founder of Global Blood Resources, the maker of the Hema Bag, blood salvage device for salvaging blood from extracorporeal circuits. And I will be talking about that in little bits tonight. So when we talk about, and again, this is going to be sort of 101 as well. So let me just start here with the ethics of blood management. First, the old primum non nocere, do no harm. When you transfuse, you want to only transfuse what is absolutely necessary. In the old days, they used to say things like, is crits down? Can I give me a unit of blood? They're like, well, give two. That's not how you do it anymore. It's give one, recheck to see if you need to give another. So again, only what's absolutely necessary and only sparingly. You want to use the freshest components possible. I think everybody have seen older blood get really dark, almost chocolatey, and you want to use the fresher blood. Under 15 days is supposedly the best. Then the cells are still much more intact, and there's not as much hemolysis and acidosis. You want to use minimum sampling. So we can do PEDS tubes on, a full CBC and coags on kids with PEDS tubes, but with adults, we seem to draw 3 to 5 mLs per tube. And, if you're drawing 3 tubes a day or, 3 sets of tubes per day, you're causing an iatrogenic anemia. You want to avoid waste. You want to recover as much autologous as possible. You want to use point-of-care labs to justify your transfusions. You want to use evidence-based medicine to guide your decisions. And you got to remember, it's not blood management, it's fluid management, and blood is just one of those fluids. Now, there is an article that came out last year, and it talked about the crisis and the sustainability of the U.S. blood supply. So I would encourage people to look at that if they can. So again, starting, what is blood? Well, we know it starts off in the large bones as pluripotential cells, and then it differentiates out into anything. White cells, platelets, plasma, skin, hair. So the 4 major components, what we're talking, we're always talking about, red cells, white cells, platelets, and plasma. Of all the blood products that are given to patients, there is one that causes trolley. Okay, so again, of all the blood products, the one the most likely is going to cause trolley, which is the number one reason for morbidity and mortality for transfusions. It's from FFP. So what happens is, women that have delivered or had children already, if they donate their blood, their FFP seems to be the hallmark for people that end up getting trolley. And again, trolley, transfusion-related acute lung injury. You get a whiteout, you get on a respirator longer. It's the number one reason why people have morbidity and mortality from blood products. So when we talk about the multidisciplinary approach or people in the chain, remember, it's door-to-door hemovigilance or it doesn't work at all. So you have your primary doctor that you normally visit once or twice a year, a cardiologist, an admission care person, anesthesia surgeon, perfusionist, the ICU care team, nurses hospital-wide for that matter, and you have administrators as well. It only takes one weak link in the chain, and a patient is then exposed to donor allogenic blood products. So it takes a hawk-like multidisciplinary teamwork, and that's the only way that it works. You have to treat every patient like they were a Jehovah Witness with a small BSA for best practice outcomes. So getting back to the players, the primary doctor, you're out shoveling or you're doing some hard work in the yard and you get some chest pain, you go see them and they start to do base lab work with you, lab work. Preferably, again, 6 weeks earlier than your surgery would be ideal unless it's really acute. Do you want to use microsampling or PEDS tubes? They may consider iron therapy or EPO therapy to get you tuned up with your red cell mass before you go for surgery. This primary doctor may suggest a good hospital for you or a good cardiologist, and that'll help select maybe a surgeon for you as well. So the cardiologist, when we work with cardiologists, and I know a lot of the listeners will have been in a cath lab and they've seen this before. But again, you want to do the minimal labs with microsampling at all times. You want to pay specific attention to bleeding during the cath. Now, a lot of times in the old days, they used to do femoral caths, and they used to put the introducer in, and then they would take it out, and they would let it bleed to make sure that it was patent. And you'd lose anywhere from 200 to 300 mLs or even more in that just to make sure it was patent. The other thing that they used to do, I haven't been in a cath lab in a while, but they used to like to use heparin, and they would have that ACT machine ring out like almost 1,000. If they thought it was greater than 500, they'd give more heparin. So the deal is, of course, nowadays we all know that we don't need 999. We can get by just fine with 300-400. All right, the use of newer antiplatelet drugs is best. Less is best. You want to identify the best hospital to have surgeon at. You want to identify the best surgeon to do the cases, a real specialist, somebody that does Jehovah Witnesses. And again, if you have more than 2 easy stents without stent jail, send me to cardiac surgery as grafts last longer. The overall mortality rate for on bypass mid-sternotomy is less than 2%. Everything else is 5 to 10%, mid-cabs or off pumps or all that kind of stuff. So again, if it's less than 2 and it's easy without stent jail, get the surgery. All right, now you have your admission care team. Preferably the day of surgery, you come in early. You've already, been without any food or water for 12 hours. You want to do microsampling. You got to remember that once they put an IV in, that's when the games begin, because now they have access to give you fluids. And for every liter of fluid of crystalloid given, only 2 to 250 mLs will stay intravascular where they want it in 30 minutes. The remainder, or the 750 mLs, will cross extravascularly, cause an organ edema and organ dysfunction, and that really drops the viscosity and call osmotic pressure. You should never give patients IV fluids unless there's an excessive volume loss from urination or bleeding. Perspiration and insensible volume loss are negligible in a perioperative setting and may amount to about 1 liter or so in 4 hours. But if you must give volume, we all know there are 2 types. There are crystalloids and there are colloids. And crystalloids are aqueous solutions of mineral salts and other water-soluble molecules, and colloids are generally larger insoluble molecules such as albumin, gelatins, and blood itself is a colloid. So when we look at the crystalloids that are given, we can see these are the ones that we deal with on a daily basis. And as I said earlier, for every 1 liter of crystalloid fluids given to a patient, only 200 to 300 mLs is going to remain where you want it in 30 to 45 minutes. Dilution leads to organ dysfunction and a coagulopathy. If you see the guy on the left, he's a happy camper. His crit's 40 and his lungs are nice and clean. And if you look at the person on the right, he's gotten too much volume. His crit's only 23, and you can see he's already having problems. And as you know, fluid always wants to find its lowest level or equal out. So you're going to have a low solute concentration. That water is going to move to the higher solute concentration to equal out. So before surgery, the pre-game plan, or the big 3, what I always say, perfusion, surgeon, anesthesiologist, whenever possible, the members of the cardiac team should try to communicate before the surgery starts. The surgeon, anesthesiologist, and perfusionist should meet prior to surgery and discuss the best course of action for optimizing the case and avoiding allogenic blood products. Remember, it's a team approach to blood management. I always liken it to everybody's playing an instrument, And if one person is not playing the same song, it sounds awful. But when everybody's playing the same tune, it sounds great and it works well. So when we talk about anesthesia, on the top left there, it says 8 grams to 10 grams of hemoglobin, and I'm going to come back to that. So with anesthesia, it's meticulous placement of lines to function correctly and not lose any blood or make any extra holes. And remember, the new residents start in July. Usually it's late June or early July. They're around and they're learning on you, the patient. You want to limit the amount of crystalloid given during the case and opt for colloids like albumin instead for volume. This is a huge one, vascular tone or SVR. You want to, gingerly use pressors as tolerated by cardiac index to achieve a normal SVR between 8 and 1,300 dynes per centimeter squared. Acute normovolemic hemodilution is a technique that's been used for years now. I think it's a good thing to do. There's a lot of people doing it. But usually you can take 1 to 2 units or more, can be removed safely and still keep a good crit while on bypass. And this blood will be rocking off outside of your body until the end of the case, and it's the first volume you'll see after the case. And there's a lot of reasons why people say they use it, because the platelets are not as beat up, but I don't necessarily agree with that. Targeted pharmacotherapy, Amicar, DDAVP, recombinant factor 7A or Novo-7, vitamin K, K-Centra is a big one now. K-Centra's got factors 2, 7, 9, 10. It's got some fibrinogen, protein CNS, AT3, albumin, and it's even got heparin in it. Red cell mass actually contributes to hemostasis by pushing the platelets out to the endothelium where they come in contact with the denuded endothelium. But it's got to be a crit of at least 24. If you look at those little white dots, if you look at this, we'll call this an artery. We cut it, we're looking straight down the middle. You'll see the heavy red cells stay and tend towards the middle like a freight train down the middle. And it pushes the platelets to the outside of the perimeter where they will come in contact with the endothelium. When the crit's less than 24, those little white dots or platelets, they tend to mix towards the middle and they don't necessarily do what they're supposed to do. So a crit of 24 is key. Anesthesia. Continued again, hypotension is not hypovolemia. There's a couple of great articles. One of them is from a guy named Chappelle out of Germany. He wrote a paper, and I would fully advise everybody to read that paper. It's logical fluid management for surgery. All right, you want to push the SVR, not the Starling curve. You want to keep it normal, 8 to 1,300. Hemodilution is the enemy. Over-hemodilution is the enemy. It leads to organ edema and organ dysfunction. That leads to morbidity and mortality. But more so, hemodilution creates a dilutional anemia and a dilutional coagulopathy, and that leads to blood products. And that has its own morbidity and mortality. So you want to give as little volume as you needed, and you want to keep the patient tight until you can ultrafiltration post-bypass. You can also hemoconcentrate during the case as well. When you're given large doses of plege, you got to get that clear fluid off. So now we're talking about the surgeon. You want to communicate clearly during the case with the surgeon, and him too. He's got to communicate clearly with you, and he's got to work diligently. There's a lot of surgeons that want to talk about their kid's basketball game or their skiing trip or whatever, but when the clamp's on, you really should just be working diligently and moving along quickly. The surgeon in the beginning should have patience with the perfusionist while they're wrapping. You want to refrain from cooling as much because it hurts and stuns the platelets. You want to use meticulous surgical technique. It should always be employed throughout the entire surgical procedure when there's bleeding. So whenever there's obviously surgical bleeding, the surgeon should stop, tie down or cauterize the area to reduce the waste of blood. And of course, always, if you have microwear, I say stop and fix it. Microwear, microbubbles. Remember that a transfusion of any allogenic blood product is an organ transplant, but we don't treat it like an organ transplant. You need to think of it like that. It's not just another medication without side effects. You need to treat everybody, every patient, like it was a Jehovah's Witness. Now the perfusionists. Perfusionists need to condense their circuits safely down. most perfusionists are around 1 liter to 1,400 mLs now. If you get it much smaller than then, you run some risks of safety and reaction time for air and your circuit going dry. So again, you want to make sure that you safely condense your circuit. You can calculate the post-dilutional hematocrit, protein levels, and call it osmotic pressure values before you even go on bypass. You want to wrap and vap both sides of your circuit with the help of anesthesia and the surgeon. This is not only proven to be very effective in many studies, and it's very cost effective as it costs nothing. You want to add albumin, osmotrol, to increase the call it osmotic pressure, to diurese the patient. You want to limit the cell washer to the pre and post heparinizations periods. Use the pump coronary sucker during heparinization period to preserve frank autologous whole blood lost outside the heart, inside the pericardium, and return it back to the patient's circulation. A waste sucker should be kept in the field for undesirable shed blood and irrigant solutions. Or if you want, you can use a cell washer for that too. You have to have on-site coagulation monitoring like TEGs, Sonoclot, heparin concentration determination. The HepCon is a great one. These are all essential tools in determining hemostasis. You want a targeted pharmacotherapy, so antifibrinolytics, desmopressin. They're all integral part of to prevent transfusion of donor allogenic blood products. Hemoconcentration. Hemoconcentrators should be considered for use on almost all cases with this excessive fluid administration, especially large doses of the single-dose pledge stuff. You want to eliminate undesirable byproducts, including antiplatelet meds. You want to concentrate the patient's red cell mass and plasma proteins during the case as well as after the case. And again, once off bypass, salvage the circuit with ultrafiltration so you don't waste any of the patient's own viable and vital blood fractions and components. The big bang of hemofiltration, the re-beginning of a new era. So way back in 1991, NIAC wrote a paper about muffing with kids and ultrafiltration. So what does it do? Of course, we all know it removes selective plasma water. Anything that's less than 50K Daltons, that all comes off, including Integralin, ReaPro, Agristat, Plavix. Those things can help come off. It conserves obviously all your blood products, your platelets, your clotting factors, albumin, but it also reduces the aflatoxins, C3A, C4A, C5A, IL-1, IL-2, IL-6, IL-8, TNF-alpha, myocardial depressant factor, and bradykinins. It improves organ function, cerebral oxygenation, pulmonary compliance. It reduces postoperative blood loss for transfusions, and again, removes platelet activating factors. It's an adjunct to diuresis of the patient of fluid retention. So what did NIAC say? He said, this is something that works really great for the prospective randomized trial. He said, why are we throwing away this blood from the circuit at the end of the case when the platelets are still working? This was a study I did with one of the universities, and it just looked at how much volume comes off with an ultrafilter. And these are adult ultrafilters, and it's anywhere from 150 to 173 mLs per minute at 500 to flow. So when we're processing end cardiopulmonary bypass circuit blood, there are 3 methods for getting that volume back to the patient. You can directly put the legs down, dilate them out, and tank them up. Give me 100, give me 100, give me 100. You can cell wash it, or you can ultrafiltrate. And of course, when you look at this graph, on the left-hand side, you can see the different types, direct, cell washing, and ultrafiltration. And on the right across the top, you can see the percentage hematocrit, the platelet count, the fibrinogen, and the percent of clotting factors. Cell washers do a great job at saving red cells, but they're not so much the other stuff. Direct infusion, of course, has a lower crit and more diluted blood. Ultrafiltration, when concentrated, it gives you a better crit. It gives you a better platelet count, obviously fibrinogen, and a larger percentage of your clotting factors. And again, here's the ultrafiltration Hema Bag versus cell washing. The issues are on the left, and then you have the 2 columns. So you have clotting factor preservation is better with ultrafiltration. The protein fibrinogen preservation is better with ultrafiltration. Avoiding allogenic transfusions is better with ultrafiltration. Both can they concentrate some of the drugs, but cell washing definitely removes more heparin. The platelet, RBC, WBC preservation is better with ultrafiltration. You can remove some cytokines and aflatoxins as well with cell washing and ultrafiltration. Contamination is not with ultrafiltration, but believe it or not, because that cell washer wand is sucking air the entire time throughout the entire case that it's on, every time you check, you'll have bacteria in the cardiotomy reservoir. So fat removal, Hema Bag will not, or the ultrafilter will not remove fat like a cell washer would. But cost savings, again, cost savings are decreased with avoiding allergenic blood products. And of course, some cost savings with reduced allergenic RBC use. So this is the product, the Hema Bag. And again, it's ultrafiltration. Here's a diagram of how it's used. And that picture is, remember, this is supposed to be a 2-liter bag, but we blew it up just to see how much volume we can get in it. And in an emergency, you can definitely get 2.4 liters in it. So the Hema Bag is an easy way for perfusionists to save extracorporeal circuit blood quickly and easily. It also keeps your circuit safely primed in case you have to crash back on. The process takes 8 to 10 minutes from aortic decannulation to anesthesia's infusing back this powerful unit into the patient. It allows you to hemoconcentrate both during the case and at the end of the case. So it's got a dual use. The end product is a hyperoncodic autologous whole blood packed with viably functioning platelets, clotting factors, albumin, plasma proteins, and RBCs with no morbidity or side effects. Remember, this is your own blood. It's got every key to every lock in your body. You're not going to have a problem from your own blood. So I want you to remember this picture. We call it the big picture of whole blood. And you can see red cells, white cells, platelets, and plasma. And that's what you have in your body. So here we're talking about, before you go on bypass, you have 2 separate circuits with 2 different volume types. The patient has the whole blood, and generally the circuit has crystalloid fluid. But when you go on bypass, now you have 1 circuit with the same volume type. It becomes a diluted whole blood at this point. When you come off of bypass, now you have 2 circuits again, 2 separate circuits, but now it's exactly the same. Whatever's in the patient is in the circuit. There's no difference. The same platelet count, same fibrinogen count, everything is the same. There's no difference. How you process that circuit changes the outcomes when fluid overload is an independent predictor of mortality. Remember, there's 3 reinfusion methods: direct reinfusion or tanking the patient up, cell washing, or ultrafiltration. And you do this at the end of the case. So fluid shifts in microcirculation, osmotic pressure, lymphatics, and organ edema, they are the new frontier for improving patient outcomes by teams in cardiac surgery, along with hemostasis when dealing with diluted blood. Fluid overload is an independent predictor of morbidity in cardiac surgery patients, as well as a direct trigger for transfusions, which carries its own evidence for morbidity and mortality. The ideal end product given back to the patient would be autologous blood, concentrated autologous blood with a high crit, high albumin, high total protein, high platelets, normal electrolytes. There's not like it has a high K or an out of whack sodium, normal electrolytes, very high fibrinogen. The process is very quick, 8 to 10 minutes. It keeps the circuit safely primed in case you need to crash back on. And again, it's all autologous. So the patient gets their own blood back. So again, it's a 3-step process. You want to come off bypass. You want to fill the Hema Bag off the field of surgery from the aortic cannula. You have a line that goes off the field. You Hema Bag to the Hema Bag. You fill it that way. You want to concentrate that, multi-pass hemoconcentration. So it takes 8 to 10 minutes. And then all you have to do is give it the anesthesia. They spike the spike port body, and they put that volume right back into the patient. So what are the changes, the functional changes in whole blood? What we did is between 8 and 11 patients, and we sent these to ITCC at the University of Pittsburgh, their blood laboratory. And we looked at the pre-processing in blue, the post-processing in green, and the percent change. And of course, the p-values are all great. So the ones we all hone in are the INR, the fibrinogen. Some people look at factor 7, von Willebrand. But platelet count and platelet function, those are really important. And again, as you can see from the blue to the green, everything was statistically improved. And you can see in this diagram as well, everything in a red box is a normal value. Pre-processing, you can see everything except for the factor 7 and the factor 9 was out of whack. And then after concentrating, everything came back into the normal or exceeded the normal level. So what's the next evolution in autotransfusion for extracorporeal circuits? Ultrafiltration has the benefits, as we said, of quickly concentrating, saving everything for the patient. So again, improved coagulation. Pre-op on the left-hand side, intra-op, everything kind of goes out of whack. But post-op, after you've returned this ultrafiltrated blood, everything almost comes back to baseline normal. You want to see as little chest tube as possible, around 1 to 300 mLs, and a lot of it can be just serous fluid. It doesn't have to be red cells. So the goal here is to have as minimal chest tube drainage postoperatively as possible. So Jeff Riley and I wrote this paper back in 2007. This is an online autotransfusion waste calculator paper. So people could go online, even during a case, and enter their values into this waste calculator, and it would tell you how much volume you were discarding and what it would cost. Now, granted, you would need, let me back that up a second. You would need to know from your blood bank how much your platelets cost, your albumin, your fibrinogen, all those things. But everything in the green is something that you can add in. Everything in the yellow is a calculation. So you can see that if somebody was to process 2 liters with a crit of 25 coming off pump, platelet count of 140, protein count of 4, and a fibrinogen level low of 120, you would be throwing away about $4,200 worth of autologous blood products to the waste bag if you cell wash that blood. So postoperatively, this is important. The nurses and the ICU care team, you want to make sure you have normothermia. You don't want patients shivering. You want to make sure normothermia, they clot better. You want to do microsampling as little as possible. You can rely on these oximetry devices now. They're amazing. The company called Massimo has one that's a sticker that they're getting approval for in the OR, and you can slap this on the patient's thigh just like you would for a balloon. You can also have the digital one or the one you put on your ear or whatever, but those tend to, when you drifting or cold, they don't work as well. They're amazing. They are absolutely amazing. You can actually get an arterial waveform off of these, and it will tell you your hemoglobin, and it's very, very accurate. I tried it myself, and it was dead on. So again, careful and judicious use of volume is needed. Pressors instead of volume, colloids instead of crystalloids, diuretics if necessary. And here's a key. You want to extubate as soon as possible. And why is that? Because they're certainly not going to let you out of bed unless you're extubated. So you want to extubate as soon as possible. Lastly, no drive-by transfusions from on-call staff. When I say drive-by transfusions, what I mean is in the middle of a night, they call up the resident. He's been busy. He's been running around. And they say, hey, Dr. Jones, Mr. Johnson's hemoglobin or his hematocrit's down to 21 now. And without even getting out of bed, he just says, give him 2 units of red cells. He never got out of bed. He never went to see why his crit was down. That's called a drive-by transfusion. So you want to have no drive-by transfusions. Lastly, hospital administrators. You want to get to know your hospital administrators on a personal basis. You want to suggest benefits of a blood management program. You want to get them involved as well. You can look at consultants. Now, 3 of these consultants were doing really well, but there's only 1 left now, Strategic Blood Management. Those are companies that you can hire to come into your hospital and show you what you're doing wrong, and they'll give you a report. It'll cost you a lot of money, but you'll get the full clean bill. Again, you want to encourage trials of new equipment and drugs, and this is really important. You need to find a champion for blood management. When I talk about being a champion of the big 3, meaning surgeon, perfusion, anesthesiologist, you have to have 2. It can't just be the perfusionist that wants to save blood. It's got to have a surgeon or an anesthesiologist. 2 of the 3, and it goes. 1 of the 3, it never works. So you got to find a champion for blood management. It's easy to show them the facts on how savings for everybody. And if you start saving money for your hospital administrator is going to be one happy camper. You might even get invited to the big hospital Christmas party with the CEO. You never know. So that's it for my first half of my presentation. And Joe, I think you want to take questions when? In the middle or at the end?
At the end, if we may, please. And so, Keith, thank you so much.